More importantly, from my perspective, so neoadjuvant therapy allows for radiographic and biochemical monitoring of response to that systemic chemotherapy while the tumor is still in situ. This is important because we know from the COMPASS trial that about a quarter of patients have a basal-like Moffitt subtype molecular profile, which does not respond to FOLFIRINOX therapy. In a surgery-first approach, we're limited in our ability to see if the chemotherapy is actually working in the residual microscopic disease. Another thing that I wanted to emphasize actually is that the goal of neoadjuvant therapy is not to downstage the tumor to make it technically easier to remove. In fact, the tumor-vessel relationship is often the same after neoadjuvant therapy, whether or not there's radiographic response by RECIST criteria, which in and of itself occurs only 20 to 50% of the time. However, as you'll see in the next couple of slides, the rates of R0 resection and node-negative disease are higher following neoadjuvant therapy. So all told, I think neoadjuvant approach avoids an unnecessary, highly morbid surgery for patients who progress on systemic therapy and essentially allows a test of time for tumor biology and patient host factors. Now, Ignacio had mentioned my very esteemed and beloved mentor, Doug Evans. So almost 30 years ago, Evans and colleagues at MD Anderson showed that neoadjuvant treatment sequencing with preoperative chemoradiation with 5-FU plus 50/40 gray IMRT accurately dichotomizes patients into those who would benefit from surgical resection and those who wouldn't. Since then, his group at MCW, Medical College of Wisconsin, has continued to publish single institution and multi-institutional retrospective and prospective studies in support of a neoadjuvant and more recently total neoadjuvant approach. In their phase 2 clinical trial of molecular profiled neoadjuvant therapy, Tsai et al. Looked at 6 specific molecular targets which were predictive of chemosensitivity. These included thymidylate synthase, excision repair cross-complementing protein, and topoisomerase 1. Neoadjuvant chemotherapeutic regimens were tailored based on the molecular profile of biopsied tumors. From 2012 to 2017, 130 patients with resectable and borderline resectable pancreatic cancer were enrolled. 107 patients, or 82%, completed all intended neoadjuvant therapy and surgery. 61 of these patients had resectable disease, 69% had borderline resectable, so roughly half and half. The median overall survival for those 107 patients who successfully completed all therapy was 45 months from diagnosis. 44 months for resectable disease and 46 months for borderline resectable disease. The R0 rate was 81% and node negative rate was 50%. Rates of local recurrence were 4%. Now you'll recall from the adjuvant trial, right, the R0 rates were closer to 40 to 55% and node negative rates were 20%. Whereas rates of local recurrence were 30 to 50%. So these results are actually similar to contemporaneous studies performed by other groups at Mayo Clinic, Mass General Hospital, and Johns Hopkins, where the median overall survival ranged between 50 to 60 months from diagnosis. And these are, remember, in locally advanced or borderline resectable patients. So the R0 resection rates are in the 90% range and node negative ranges are about 75%. In the study by Trudy et al. From Mayo, 194 patients underwent resection after total neoadjuvant therapy. It was about 63% were borderline and 37% were locally advanced. So FOLFIRINOX and Gemnab were used in 85% of the patients. Radiographic downstaging was uncommon and occurred in about 28% of patients, and vascular resection was performed in a similar number, 28% of cases. Here, their R0 rates were 94%. The authors found 3 factors independently associated with prolonged survival, and that included the receipt of 6 cycles or greater of chemotherapy, an optimal post-chemotherapy CA19-9 response, and major pathologic response by histology. Now, in the study by Murphy et al. At MGH, 49 patients with locally advanced pancreatic cancer underwent 8 cycles of FOLFIRINOX and losartan, followed by short course or long course chemoradiation therapy, depending on persistent vascular involvement. And actually 84% of those patients ended up having to undergo long course radiation therapy. And from their data, so they had 49 patients, 42 of whom ended up going to surgery and 34 resected. 30 of those 34, or 88%, had an R0 resection, and the node negative rate was 74%, with the median overall survival for those patients being 33 months. And now the Hopkins study is very similar, median overall survival 35.3, R0 resection rate is 89, and from the Hopkins group, 60% of patients received FOLFIRINOX or modified FOLFIRINOX therapy, and nearly all those patients underwent chemoradiation with SBRT. So just to be a little bit pedantic here, this slide highlights criteria for clinical staging based on the tumor vessel relationship as assessed on high quality contrast enhanced preoperative 3-dimensional imaging. The MCW criteria are not significantly different from those found in NCCN guidelines. The main difference is that MCW divides locally advanced into types A and B based on the degree of arterial involvement, with locally advanced type A being resected following extensive course of total neoadjuvant therapy, while the locally B typically are not. Additionally, it's important to note that the narrowing of the splenoportomesenteric confluence has significant impact on resectability due to technical challenges it possesses. So cavernous transformation of the portal vein due to obstruction or severe narrowing of this confluence often renders surgical removal of the pancreatic head near impossible due to risk of variceal hemorrhage. This is a coronal CT scan that demonstrates cavernous transformation, all of this white here, with varices around the portal vein marked with a PV. The black arrow, which I don't know if you can see very well here, identifies the common hepatic artery, while the white arrow marks the superior mesenteric artery. Cavernous transformation such as this can be addressed with a temporary mesocaval shunt, which allows for safe removal of the head of the pancreas. And in these intraoperative photos, the one on the left, there's a temporary mesocaval shunt that's been created from the superior mesenteric vein marked SMV to the internal jugular vein graft IJ VG to the inferior vena cava, the IVC. So head of the patient is up here, feet are down here. This is the IVC going up and down. Here's your superior mesenteric vein, and here's our conduit from the IJ, creating the temporary mesocaval shunt. The common hepatic artery is marked with a HA, and the transected portal vein is marked with this white arrow here. In this tumor, in this photo, the tumor has already been removed. And then on the right side, you'll appreciate that the superior mesenteric vein is now in continuity with the portal vein here. The previous internal jugular vein graft to inferior vena cava has been taken down right here, and that's marked with an asterisk. So when discussing vascular reconstruction, invariably the question arises as to whether such operations are really heroic. When it comes to pancreatic cancer and surgery, I believe it's necessary to balance three factors: the tumor, the patient, and the operation. And only one of these can really be high risk. So one adage that I have, that I carry with me from Dr. Evans, really is, you do not operate on a high risk patient who needs a high risk operation and has a high risk tumor. So that high risk patient, if they have multiple comorbidities and needs a high risk operation such as vascular reconstruction, you've got to make sure that it's not a high risk tumor with a high likelihood of recurrence. So this requires commitment to multimodal therapy, where survival, duration, and quality of life are the primary endpoints. And as mentioned previously, total neoadjuvant approach allows for the test of time, tumor biology, and patient host factors. And so these heroic operations only occur when they've proven the test of time, where the biology is such that we think, or we're optimistic, that the systemic therapy is controlling the disease. Returning back to neoadjuvant therapy, I hope I've illustrated the growing body of literature from several high-volume pancreatic centers in support of total neoadjuvant therapy for at least borderline resectable and locally advanced disease. So 246 patients randomized from 2013 to 2017, pre-op chemo / chemo radiotherapy arm consisting of 3 cycles of gemcitabine, combined with 15 fractions of 2.4 gray during the second cycle, followed by surgery, and then 4 cycles of adjuvant gemcitabine. The second arm consisted of immediate surgery and 6 cycles of adjuvant gemcitabine, with the primary endpoints being overall survival by intention to treat. The resection rates were not different between preoperative chemoradiation therapy and the immediate surgery group, so 61% versus 72%. However, the R0 resection rates were higher in patients treated with preoperative chemoradiation therapy, 72% versus 40%, and fewer patients had pathologic lymph nodes, 33 versus 78%. Now, these numbers are very consistent with the data from the locally advanced disease that we have previously discussed. So the overall survival by intention to treat, though, was not statistically different. However, disease-free survival was better following preoperative chemoradiotherapy. And then when the subset of patients who underwent surgical resection and started post-operative chemotherapy was analyzed, the overall survival and disease-free survival was improved. However, these differences are likely driven by the differences seen for borderline resectable patients. So when one examines the group of resectable patients only, there's no statistical difference between the 2 treatment arms for any of the primary or secondary outcomes as seen in this purple box over here. So thus, at this point, I have to say the jury is still out regarding total neoadjuvant therapy for resectable disease. Personally, my bias, I acknowledge it, the theoretical arguments are still very compelling, and this data to me supports that there's no harm in providing neoadjuvant therapy to patients with resectable disease. Specifically, a window of opportunity, a window of surgical opportunity is not lost based on the rates of resection, and the toxicities from neoadjuvant therapy do not negatively impact the patient's ability to tolerate or undergo surgery. So as I wrap up, I just wanted to highlight the total neoadjuvant approach that we took at Medical College of Wisconsin. So following diagnosis of pancreatic cancer, patients are started on neoadjuvant therapy, typically 8 cycles of FOLFIRINOX or 4 cycles of Gem-Nab paclitaxel. Patients are then followed with imaging and laboratory studies every 2 months throughout the neoadjuvant period. If CA19-9 levels do not decrease, or if the tumor appears to increase on imaging, then the chemotherapy regimen is changed, typically from FOLFIRINOX to Gem-Nab, and the determination of operability is made prior to the initiation of chemoradiation therapy based on imaging, patient performance status, and the availability of social support in a multidisciplinary conference before starting the chemoradiation. So clearly this is not the only way and not the only approach. And actually many controversies exist regarding the chemo backbone and the duration of therapy. Even more so, the use of radiation therapy in neoadjuvant setting is highly contentious. So there are multiple studies that are ongoing in the US and in Asia and Europe. And I think this is my segue to Dr. Lloyd. And before I do that, I just wanted to end my portion with this slide that highlights all the people involved in the pancreatic cancer program here at the Huntsman. And I apologize if I've left anyone off the list. You know, we all would not be here were it not for our patients and the patient's family who inspire us every day and give us hope for new discoveries in the diagnosis and treatment of pancreas cancer.